Hi, great. Hi.
Good evening.
Good evening, sir.
Yeah.
It is just joining now. Yeah.
Yes.
Ashlesh,
You are taking the questions today?
Surya Prakash sir is in.
Unmute yourself, beta.
Good evening, sir. Good evening, sir. We can hear you.
No, I was asking Ashlesh.
Yes, sir. I have unmuted myself.
Yeah. Hi.
We can hear you, sir.
Who else is taking the questions? Who are the volunteers today?
Paras sir and Ashlesh.
Okay. Good. Good. Sir is joined. We'll just wait for 2-3 minutes, okay?
Yes, sir.
Amit sir, please make Dr. Gaurang Shah host. अभी मैं ट्रेन से उतरा तो सर मेरा नेटवर्क
Rakesh, I made you the host. Okay, so can you? I made Gaurang Shah sir co-host.
Okay, sir. Okay.
बार से जेतू उधर नहीं जाएगा
मुझे याद है
મારે તો આવું જ પડવાનું સવારમાં 6 વાગે
Sir, who is answering today?
Dr. Paras.
Hello.
Yes, sir.
Yeah. Who are all are answering?
Sir, I am Ashlesh, sir, and somebody Paras is also participating.
Dr. Paras and Dr. Ashlesh.
Okay. So Ashlesh, we had given you some outline, correct?
Yes, sir.
Now, means what are the types of questions they ask in exam when you select the instrument? So I hope that you have gone through that questionnaire, because it will be very easier for you also to answer, as well as, if we ask you question, we don't waste much time.
Yes, sir.
So Gite sir, Maheshwari ji, welcome. So we start now.
Sir, good evening, sir. Yes, sir.
Good evening. Yeah. Brijesh?
Yes, sir.
Sir, I'm not able to see Dr. Paras.
I have unmuted. Hello.
Yeah. Okay. So let us start with the paras only. Paras.
Yes, sir.
Yeah.
Hello.
So you know how to answer in exam.
Yes.
So you start this so that Ashlesh will later on he will also understand. So describe this instrument.
Sir, this is a igneous continuous irrigation system used for prostatic resection. The upper instrument is assembled outer sheath with inner rotating sheath. The middle one is the inner rotating sheath with distal ceramic tip, and the lower third one is the visualizing sheath with the working channel, also known as visualizing sheath of Schmidt. These instruments are made up of stainless steel. They can be sterilized using autoclave or ETO, plasma sterilization, or if we need the instrument for some surgery under a short duration, we can use 2% glutaraldehyde also. For the upper instrument, the outer sheath consists of a sheath with some serration at the end, distal end for outflow, uh, and there are one at the proximal end. There is a inflow and outflow attachment, and at the proximal end there is attachment for with a locking mechanism for the rotating sheath.
Now the three things. First, you said this is for the resection of the prostate. So that is very incomplete. You cannot say that. Okay, which is used for the resection. Correct? Because it can be bladder tumor. It can be many. Right or wrong?
Yes.
Second thing is you are saying this. The small holes are there at the distal end. That is for inflow. Is it for inflow?
Outflow, sir. The fluid from the bladder, it will enter through the serrations and it will travel between the inner sheath and the outer sheath and come out via the outlet on the downside of the proximal end.
Now you can see that outlet and inlet. Okay, the outlet is more distal and inlet is outlet is more distal, or you can say proximal towards the patient body. Correct? And
Yes.
this is distal. Why it is like that?
So it is usually designed this way to prevent the working element to strike, because the finger bow of the working element are going much farther away from the thumb, so that there will be a good ergonomy.
Yeah. So the one reason is because the inner tube, okay, is coming right up to the end, and it is longer than the outer sheath. And second thing is that when the working and you're using the working element, okay, your finger part that should not be very near to the channel. Otherwise, you cannot hold it properly. Your finger will not go inside. So when you assemble, then only then you will come. Okay. Gite sir, please start asking them question. Maheshwari.
Yes, sir. Whenever this instrument is kept in the exam, so you should start with it is a resectoscope, outer and inner sheath. Resectoscope is classified as per the size of, as per the beak, as per the sheath material, as per the irrigation, and as per the rotation. So the size is, everything 24, 26, 27 or 28 French. Depending upon the beak, it is a short, long or oblique beak. Depending upon the sheath material, it is Teflon or MTC. Depending upon the irrigation, it is a continuous irrigation or conventional irrigation, and rotation. So rotatory and non-rotatory. So if if you want to go in detail, then what is the benefit and losses of long beak? What is why there is a short beak? So long beak it will help in occluding the vessels during the resection, but the vision is poor because there is a continuous loss of fluid. And short beak is what is the drawback of long beak is overcome by the short beak. Then another classification is rotation. So why there is rotating? What is the rotating receptoscope? Rotating receptoscope means what? So there is no any entanglement of the tubics can be avoided, one thing, and the position of the sheath and telescope is in the desired position without rotation. There is no need to rotate for the person as well as for the sheath. That is not required. So that is called rotation is only from the outside. Sheath is not rotated. Camera is rotated. Agreed. So that's why the ट्यूब एंटेंगलमेंट नहीं होगा और ये ऑलरेडी लास्ट क्लास में हमने डिस्कस किया है और जो सर्जन के जो नेगेटिव पार्ट्स है लाइक सर्वाइकल स्पॉन्डिलोसिस और स्पाइन रिलेटेड इश्यूज है वो अवॉइड कर सकते हैं देन इरिगेशन में भी कंटीन्यूअस इरिगेशन व्हाट इज द कंटीन्यूअस इरिगेशन व्हाट इज द कन्वेंशनल ये सब चीजें तुमको पता रहना चाहिए तो ये ऐसा अगर तुम डिटेल में अगर एक्सप्लेन करते गए तो एग्जामिनर को कुछ पूछने की जरूरत नहीं आएगी ये सब रिसेप्टोस्कोप के साथ में फिर ऑब्चुरेटर्स आएगा फिर वो कौन से टाइप्स ऑफ ऑब्चुरेटर्स है तो विजुअलाइजिंग ऑब्चुरेटर्स हर बार अपन बोलते हैं उसका नाम पता रहना चाहिए उसके बाद में स्टेट ऑब्चुरेटर है हिंज्ड ऑब्चुरेटर है ये ऑब्चुरेटर्स के टाइप्स है व्हाट इज कॉमनली यूज्ड व्हाई देयर इज व्हाई वी आर यूजिंग द विजुअलाइजिंग ऑब्चुरेटर व्हाट इज हिज बेनिफिट तो हर एक का नाम दिए वाला स्टेट डिस्टेंडिंग ऑब्चुरेटर का भी नाम है देते हैं तो वीविंग ऑब्चुरेटर का नाम है हिंज्ड ऑब्चुरेटर का नाम है तो वो नाम भी आपको पता रहना चाहिए ये सब होने के बाद में ये अगर डिटेल आप बता पाए उसके बाद में जाएगी बात वर्किंग एलिमेंट तो इसके बारे में और कुछ बताना चाहते हैं तो बाकी बता दो और पूछना चाहते हो तो पूछो क्योंकि ये सब चीजें आपको पता रहना जरूरी है टाइप्स ऑफ ऑब्चुरेटर टाइप्स ऑफ receptoscope type of classification as per the irrigation classification as per the rotation what is by continuous what is benefit what is ये हर छोटे क्वेश्चंस में अगर यहाँ अटक गए तो आगे नहीं जाएंगे तो यहाँ पे गलती के लिए माफी नहीं
Yeah, so Ashlesh, sir
Yes,
has
sir.
said there are different types of obturators. Okay.
Yes.
So
Yes.
what is an advantage of this is a visual obturator, correct?
Yes.
So what is an advantage?
Sir, we can go under vision, sir, so we can avoid the injury.
Injury to urethra, injury to prostate where the bladder neck is very high, correct?
Yes,
and at the same time, even into the bladder.
Yes.
If some tumor or something is there, it will not start bleeding. So that is number one. Okay. Second. Okay. Someone has asked what are the names of the visual obturator. What is the name?
Schmidt.
Yeah.
Correct.
Fine. Okay. Then when you will use, if I'm giving you, when you will use non-visualized obturator.
Sir,
and what is the name?
We generally use the Timberlake's hinged obturator. It comes in the combination with that Olympus resectoscope system. And when we suspect that, and we know pre-operatively that there is a large median lobe, and for that manipulation, we use the Timberlake's hinged obturator.
Okay. Or when you know there is no pathology in the urethra. Already patient is on, either you have done a cystoscopy earlier or patient is on catheter.
Yes.
So then you know, you don't want to see urethra.
So it is a negotiation of the bulbar urethra, that is S shape जो रहता है ना, वो bulbar urethra negotiation and bladder neck negotiation when there is median lobe. Correct?
Yeah.
So that is why there is a hinged obturator, or that is Timberlake obturator.
It is like a shape of dilator. Okay. Now, what are the, sir, it said there are different sizes, 22, 24, 26. What is an advantage of a smaller size resectoscopy of the thing sheath compared to the larger one? And what is the disadvantage?
The advantage is that it is smaller in diameter, and hence it will cause less injury to the surrounding urethra. The chances of the stricture will be less. Disadvantage.
Disadvantages are that it will cut a small chip, so the resection time will be increased, and the field of vision will be also less because it uses a 3 mm scope, which has.
देखो, in any type of the resectoscope, the telescope is same ना. So field of vision and angle of vision का सवाल कहाँ पे आता है?
So this smaller one, I think they are using
Sheet size. So we will cut a small chip.
Exactly. So it is related to the duration of the surgery, size of the chips what we have cut, and irrigation का issue आ सकता है छोटे में और बड़े में. तो लेकिन उसका नेगेटिव इम्पैक्ट है कि large size scope keeping for longer time inside the urethra, then there are complications like stricture urethra. Okay, smaller size scope, less complication, but can be used only for the smaller gland. For larger gland, time will be more. So ये pros and cons small के और large के आपको पता रहना चाहिए. उसका कलर कोडिंग भी है फिर हर एक का. तो कलर के हिसाब से भी वहां पूछ सकते हैं.
tell the color coding.
22 is gray in color, 24, 26 is yellow, 27 and 28 are brown.
Okay. Fine. Okay. What are the uses? Aslesh, what are the uses
What are the uses of, sir? What, sir?
of this resectoscope sheath is used? Where you will use it?
The resectoscope with sheath will be used for transurethral resection of prostate, transurethral resection of bladder tumor, and if I want to do a bladder neck incision, TURP, sir, I will use it with a Collins knife. For ureterocele incision, sir.
If there is a ejaculatory duct obstruction,
For ejaculatory duct obstruction also can be used, sir.
if there is a solitary kidney and there is a TCC in the pelvis, in the kidney, can you use it?
Yes, sir, we can use.
सिंप्लीफाइड है, जहां कहाँ रिसेक्शन कर सकते हैं वहां दूसरा और कुछ यूज करने वाले है क्या? ट्यूमर में भी इनसाइड द किडनी, ट्यूमर में भी इनसाइड द रेनल पेल्विस, ट्यूमर में भी इनसाइड द ब्लैडर, कहीं पे भी ये वाल रहो कुछ भी रहो, देयर इज ऑलवेज रिसेक्टोस्कोप. साइड पेडियाट्रिक अडल्ट रह सकते हैं. समझ गए ना? तो जहां रिसेक्शन करना है वहां हर चीज के लिए उसका यूज हो सकता है. It is depend upon the size. If it is adult, then adult का इंडिकेशन, पेडियाट्रिक है तो पेडियाट्रिक का इंडिकेशन. तो इतना सोचने का क्या जरूरी है? जो रूटीन में देखते हैं करते हैं वही बताना. बहुत बार वो एग्जामिनर सामने का जो बीक रहता है ना इनर शीथ का, वो सिरेमिक का है, बैकलाइट का है, टेफलॉन का है, दिस आर द टाइप्स. तो फिर यूजुअली सिरेमिक का यूज करते हैं, उसका क्या बेनिफिट है ये यूजुअली वो एक पूछते हैं। दूसरा बैक साइड को जो आईपीस के पास में एक जो रिंग के जैसा रहता है उसका उसका भी यूज पूछते हैं, वो पता रहना चाहिए दोनों कि क्या यूज है।
The use of the ceramic is that it is non-conducting, so it will prevent the current and avoid irrelevant injury to the
Correct.
tissue.
और बैक साइड का जो एक रिंग आता है पूरा स्कोप अंदर जाने के बाद में एक येलो कलर का रिंग आ जाता है, प्लास्टिक के जैसा रहता
Washer, it is like washer, prevents the irrigation fluid to come out.
है। No.
It's
The
a glass
area which is sit on the glans.
glass notch. It prevents excess forward migration of the
That is
excess
one,
forward.
and another is it will avoid the compression over the glans or meatus. तो glans वहां पे आके the glans will sit on that particular ring, which will help in avoiding injury to the glans. ये रूटीन क्वेश्चंस रहते हैं आगे। और
So what is TURP syndrome?
Sir, it is a set of signs and symptoms due to resection in the using the monopolar TURP with fluids like glycine, which are hypoosmolar. It will lead to CNS and CVS symptoms and signs, including hypo and hypertension, bradycardia, confusion, nausea, vomiting. And it is because of the dilutional hyponatremia with sodium levels less than 125.
You said glycine.
Yes, glycine and distill. So basically, fluids used in the monopolar TURP will lead to can cause TUR syndrome.
So mainly TURP syndrome is because of what? Water or because of glycine?
Sir, any hypoosmolar fluid, any hypoosmolar hypotonic fluid can cause TUR syndrome.
Glycine?
Yes, sir, glycine as well as distilled water, both.
So according to you, TURP syndrome occurs only in TURP?
No, sir. In like whenever you are using these fluids, sir.
Where else?
Yeah.
जहाँ पे भी फ्लूइड का अब्सॉर्प्शन होने वाला है वहाँ हर जगह पे होगा ना।
Yes.
PCNL में नहीं होता है क्या?
Yes, sir.
Therefore, you should use normal saline in PCNL.
See, there are two parts of like TURP syndrome or one is hypervolume, so body volume increases, and second thing is if you are using water, correct, then it is because of dilution of the sodium, hyponatremia. And if you are using glycine, then in that case, because of neurotoxicity, because of amino acid. But when we are talking of TURP syndrome, mainly we talk about hyponatremia caused by usage of water in monopolar TURP. So now tell us, what are the things you come across? What is the first thing that you will see?
Sir, we will check for the consciousness of the patient. If generally the patient is in the spinal anesthesia, so we and the anesthetist will keep on talking or ask questions to check the awareness of the patient. And if it's the starting symptoms will be starting with the CNS symptoms, the patient will start yawning initially. If and the bradycardia will develop, sir. Unexplained.
First bradycardia or first hypertension?
First, sir, I think it's bradycardia, sir.
Are you sure? First, the blood pressure will start rising. What will happen first? The water absorption. Suddenly the water will start increasing in the body and the blood pressure will. So that is why you every time you see what is the blood pressure, what is the blood pressure? So it starts rising and then this bradycardia. Then and then later on all CNS signs, and there will be a bleeding also
Yes.
because of increased pressure. So to prevent that, what you will do?
We should we should use the bipolar TURP instead of monopolar TURP because we use
No,
normal.
you are using monopolar TURP.
In that case, we need to limit the resection time, sir. We should.
Okay, so first is a restriction of the resection time. Second,
Sir, case selection, generally very large size gland should not be subjected, more than 70 cc gland should not be subjected to monopolar TURP using distilled water or glycine, sir. And we need to, if we should generally use the low pressure systems, like continuous, like Iglesias sheath, or if it is not available, then we can use the Reuters cannula to make the system low pressure, sir. And the height of the irrigation fluid should be kept around 60 centimeter, not more than that, so that the pressure is less, sir. The fluid absorption is less.
okay, fine. And as soon as you think that you have opened up
Sinus.
the capsule, sinus, then
So
finish your
we
job
should
and
stop immediately, and we should apply 100% oxygen. We should start giving furosemide 1 mg per kg. If there is excessive bleeding, then we should transfuse blood. If there is signs of respiratory distress or pulmonary edema, then we can give assisted ventilation.
okay, fine. Hiren, anything else? TURBT.
So everything it is depend upon the hydrostatic pressure in the prostatic area. Okay. So the proper selection of patient
Yes, sir.
means less comorbidities, size should be in the range of the monopolar TURB. Number 2, proper selection of fluid, irrigation fluid. That is 1.5% glycine. Proper selection of maintaining the height. That should be 60. Proper duration. That should be 60. That
Most
is again
important.
60 minutes. And
Most important. People go on resecting, and then problems happen.
it can be stretched up to 90, but that next 30 minutes will be for only the hemostasis, not for the resection. Okay. And if you seen if the sinuses are opened, one or multiple places, then you have to stop the things. Don't go on resecting, that fluid will get absorbed through the sinuses and patient develop TURP syndrome. TURP syndrome, there is reflex bradycardia, hypertension, mental confusion, yawning. ये सब चीजें उसमें होती है. Serum sodium less than 125 millimole के हिसाब से. तो इसका ट्रीटमेंट क्या है? प्रिवेंशन इज बेटर देन क्योर. फर्स्ट. नंबर 2, हो गया तो क्या करेंगे? तो वो कौन से स्टेज का सिंड्रोम का कौन सा स्टेज है? न्यूरोनल नर्व सीवीएस इन्वॉल्वमेंट है, सेंट्रल नर्वस सिस्टम इन्वॉल्वमेंट है, पल्मोनरी इन्वॉल्वमेंट है, वो हिसाब से उसको ट्रीटमेंट करना पड़ेगा. इफ इट इज जस्ट ओनली इंट्राऑपरेटिवली, फर्स्ट इज सोडियम पोटेशियम करना, इलेक्ट्रोलाइट करना. सोडियम का क्या रेंज है वो हिसाब से हाइपोनाट्री में करेक्ट करना है. देयर शुड नॉट बी एनी एक्यूट करेक्शन ऑफ हाइपोनाट्री. करेक्ट. तो वो हाइपोनाट्री में करेक्शन करते करते अगर समझो पल्मोनरी एडिमा के कुछ साइंस एंड सिम्टम्स है तो फिर वो स्पाइनल का केस है तो वेंटिलेटर पे डालो और उसका इंटेंसिव केयर करो. ये सब चीजें आपको बताना पड़ेगी. तो TURP syndrome, how commonly you seen in last, I have experience of near about 20-24 years. तो एक दो पेशेंट मिला हम, तो यूजुअली होता नहीं है, क्योंकि आजकल क्या है कि न्यूअर मोडेलिटीज बहुत सारी आई है। मोनोपोलर है तो बायपोलर है, वाटर के जगह भी ग्लाइसिन, एक दो प्लेसेस अगर छोड़े स्टेट के हमारे, तो जैसा जे में अभी भी हम वाटर यूज करते हैं, लेकिन बहुत प्राइवेट में मेजोरिटी प्लेसेस पे 1.5% ग्लाइसिन ही यूज होता है। थोड़ा बड़ा साइज है तो बायपोलर आ गया, और थोड़ा बड़ा साइज है तो ये उसका लेजर आया है। Availability of alternatives, good alternatives are there. So that's why the chances of encountering the TURP syndrome is going down, down and down. So this is in short about the TURP syndrome. But before reaching to the TURP syndrome, after completion of the resectoscope, last time we have already completed about the working element.
Yes.
वर्किंग एलिमेंट का भी डिटेल डिस्कशन हमने लास्ट इसमें क्लास में किया है। उसके बाद में TURP रिलेटेड चीज आएंगे, लूप्स। क्या क्या चीज, व्हाट आर द टाइप्स ऑफ लूप्स, कौन से साइज के लूप्स है, कट होगा तो कहाँ का यूज, अगर समझो सर्कल बायपोलर का लूप कैसा रहेगा, मोनोपोलर का कैसा रहेगा। उसके बाद में अगर लूप कट होगा, ब्रोकन लूप है तो उसका कैसा पता करना पड़ेगा उसको, और ब्रोकन लूप के और क्या क्या यूजेस है, थिन लूप, थिक लूप, ये सब चीजें लूप में भी TURP केस में टेबल अगर वो वही सेक्शन अगर आपके सामने आया है तो उसमें ये सब चीजें भी पूछ सकते हैं। कटिंग लूप, कोएगुलेशन लूप, रोलर बार, ये सब चीजें तुम रूटीनली यूज करते, तो ये उसके बारे में भी आपको पता रहना चाहिए। और
What has already told you, then just tell us what are the different types of loops.
They can be classified on the basis of the size. The size are available from 0.30 mm, 0.35 and 0.40 mm, and they can be classified into single stem, double stem, and on the basis of the use in the upon the energy, monopolar energy and the bipolar energy, and the for the on the size also, sir, from 24 and 26 they are the yellow color loops, and the other 27 and 28 are the brown color loops, sir. And the monopolar, in the monopolar loops, the monopolar energy has one is the other electrode is the passive element, so it is just for the stability, while in the bipolar the both the loop ends are used, sir. One is active and one is passive, sir. And in monopolar loop the current passes through the one end of the loop, and then through the tissue, and then through the patient plate. And in the bipolar loop it forms the it creates the plasma, and after the resection it returns back through the other end of the loop, sir. The
समझो लूप सेंटर में कट ब्रोक हो गया, लूप पैसिव आर्म के एक साइड में ब्रोक हो गया, तो कौन से सिचुएशन में TURP कंटिन्यू कर सकते?
अगर सर एक्टिव एंड वाला साइड अभी भी पेटेंट है तो वी कैन कंटिन्यू। जो पैसिव,
मैं आपको दो ऑप्शन दिया है, लूप पैसिव आर्म को ब्रोक हो गया है, लूप सेंटर में ब्रोक हो गया, तो इन विच सिचुएशन यू विल कंटिन्यू द TURP?
पैसिव ब्रोक हो गया है तो आई विल कंटिन्यू।
एग्री। why not in the broken at the middle?
सर वो उससे इलेक्ट्रिक करंट पास होगा, वो कोएगुलेशन कटिंग
नो 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 नो, द आर्क जो है ना, वो आर्क सिर्फ आधा, हाफ पार्ट ऑफ द लूप इज ओनली वर्किंग, current is reaching to the half part, that circle is not getting completed, and in when the passive that complete जो आर्क है उसका, वो अभी भी फिलहाल पूरा वर्क 2/3 से ज्यादा वर्किंग रहता है अगर एक साइड को कट हुआ है, ठीक है। और जो सेंटर में कट होगा उसका तुम BNI के लिए वगैरह यूज कर सकते हैं, एडिशनल कभी कभी पूछते हैं कि वो ये लूप और कहाँ पे आप यूज कर सकते हैं। थिन लूप और थिक लूप का डायमीटर आपने ऑलरेडी बोल दिया, व्हाट इज थिन लूप का क्या डायमीटर रहता है?
0.25
बराबर।
So what are the different shapes? What are the different shapes?
Roller.
So there is a loop, so there are roller the roller balls, there are conical electrode. There is a Collins knife also.
Sir did not ask you what are the different types of loops available. He asked about different shape of the loop.
Collins knife.
Have you seen any loop bent in front? Or sometimes
sir,
you bend it
तो
in front.
कम से कम स्टैंडर्ड जो 3 ट्रॉली पे रहते उतना तो बोल दो। हर एक के ट्रॉली पे 3 रखते हो ना। एक बीएनआई के लिए कोलिंस लाइफ रखेंगे, दैट इज वन राइट एंगल बोलते हैं उसको। शेप उसका अगर पूछ रहे हो तो राइट एंगल बोलो। दूसरा स्टैंडर्ड कर्व लूप है, उसमें 3 थिकर छोड़ दो, वो एक लूप है। तीसरा रोलर। ये 3 चीजें तो ऑन एन एवरेज एवरी ओटी में यूज होती है। हाँ, उसके बाद में के जो भी अगर कुछ डिफरेंट टाइप्स ऑफ लूप्स है वो रूटीनली यूज नहीं होते, लेकिन पता रहना चाहिए।
हाँ, मतलब sir was asking that sometimes you modify the loop where sometimes you can't reach the space. So you can make it in shape in front when it is not reaching the back wall or the dome, or sometimes like that. What is Thuris?
Sir, it is a brand name by the Olympus, sir, in which the plasma kinetic energy is used. And in tourist with normal this standard loop, there is one thick loop, there is one thick ring shaped structure which will help for the transurethral bipolar resection of the prostate. It will act like it will hold the tissue for support, and with that you can resect the tissue of
Correct.
the.
So you are right that it is Olympus system. It is as a special loop and it is called transurethral resection in saline.
Yes.
Okay. Just show them the outer channel and inter channel. So, so how many channels are there? Aslesh? In the continuous irrigation, how many channels will be there?
2, sir. One the inlet and the other is outlet, sir.
And what about a telescope?
Yes, for entrance of the telescope, the big.
So once you put a telescope, the one is a telescope, second is a inlet, and third is a outlet. Correct? So the water will come from where? Or fluid will, irrigation comes from where?
It goes through the lumen of the inner sheath, sir. And
so it comes out between the telescope and inner tube.
Yes, it comes out between the outer and the inner sheath.
You were right first, you changed it.
Telescope and
you said lumen of the inner sheath. You were right, no? Why did you change it?
Inside
outer and inner sheath के बीच में तो outflow है बेटा.
हाँ, ये सर मैं उसी क्या बोल रहा हूँ कि अंदर जाने के लिए इनर शीथ के अंदर से जाता है.
So that was right. No, why did you change it? That's what I'm saying.
So it is between the telescope and inner sheath.
Oh, okay. I thought you were asking about outflow later. Okay, sorry, sir.
Outflow is, yeah. So just show them. He has taken the.
Hello. Yes,
our residents have taken a special care to show all of you. Just show them.
So as we can see, sir, while putting the guide wire.
Yeah. Tell Bridget.
मुझे ऐसे याद नहीं यार, आपको मुझे आके मिलना पड़ेगा.
So we can see while passing through glide wire through the inlet, it goes from the inlet and from the irrigation sheath and comes from inner sheath. So it is between inner sheath and telescope.
मीटिंग चालू है, मैं थोड़ी देर में रिप्लाई करूंगा.
So we have a small video which will explain this. So I will show the video.
See, as you can see, is coming from inside. Okay. Right. Okay, let us.
Now for the outflow. So while the outflow, the water will return through the outer sheath and then we'll go to the outflow. So we have another video from which we have put the fluid from the outflow and we can see that it only comes through the outer sheath.
See, the connection fluid is connected to the outer sheath, and as you can see, it is coming from. Yeah. So, Aslesh, one question. Suppose by chance, in a rotating sheath, if you attach fluid to the outlet and outlet to the inlet tube channel, what will happen?
Sir, the flow from the outlet tube, if I connect by mistake, then the flow inside will be very poor and the vision will not be good. So before, if I fail to recognize it and if I start resecting, then there will be very poor vision. It will be all red. So I need to that if it is right or wrong in the first place.
Bladder will also collapse, no? Because it will get empty faster than filling.
Yes, sir.
Understood. The amount of fluid from the inlet which is going is always higher. See, your bladder, even though whatever you say, it is a low system, low pressure system, still you have realized that at the end of the resection, whenever you are doing, the bladder will be full. It will take a longer time. Okay, because there is an outlet. It is a continuous irrigation. But the in this inlet and outlet, the volume is not the same. So when you do the opposite, the amount of fluid which is going inside will be much less, and there are chances that large amount of fluid might be coming. So the bladder will not expand. So there are sometimes there may be chances that you may perforate. Okay.
Yes.
Fine. Okay. Then if you are doing a TURBT, what are the which anesthesia
Sir,
will give?
The area from which that wire is coming out, the fluid inside the bladder will come just proximal to the beak of the inner sheath. From bladder to inner sheath, and there is one area through which that wire sir has shown just now. That fluid will go in between the two concentric lumina, concentric part of the two sheath, that is outer and inner sheath, and that will go to the exit tap. So the purpose of this using of two sheath, why not only one sheath? So the purpose behind using the two sheath is to keep the bladder pressure low. So what will happen if it is not low, if pressure is more? Then what? That the ooze will be more, there will be bleeding, vision will be poor. So keeping the pressure inside the bladder is low, keep the field clear, which will help in early resection or early completion of the TURP. So time will be less. Okay. So to maintain the fluid inside the bladder at a constant capacity or level with a low pressure is the purpose behind using the two sheath. Okay.
You understood, Aslesh, what sir is trying to tell you? If there is no outlet, what will happen? There is only inlet. There is no circulation of fluid. Whatever resection you have done, there is a blood inside. This continuous bleeding, whatever maybe, it may be less bleeding, but the fluid inside the bladder will become red, and your vision will be affected. But if there is a continuous irrigation, slowly and slowly this is empty, and the vision will be clearer because a fresh irrigation is there. Understood?
Yes, sir.
That is the difference. And second thing is pressure is maintained. Fine. Now just tell me, what are the anesthesia? What anesthesia like to give in TURBT, and how will you do? What are the complications?
TURBT, sir.
Yes, TURBT.
Sir, in TURBT, sir, at our institute, we generally give spinal anesthesia with the, if the tumor is on the lateral side, then we give the obturator block, sir. Local anesthesia is instilled in the obturator fossa, sir, to prevent the obturator jerk, sir. And if we can, if spinal anesthesia, if we want to give the general anesthesia, then general anesthesia is always better to prevent the injury to the bladder wall, inadvertent injury to the bladder wall, sir.
Okay. So how will you prevent the obturator jerk?
Sir, by using, first is the general anesthesia, second is spinal anesthesia with the obturator block, and and to, by not distending the bladder too much, so by emptying the bladder at times, so that the pressure is not too much in the bladder, and that will cause the injury.
Not only that, nearer it goes to the obturator now, the more chances. So that is why you keep it low volume.
Yes.
Bladder. Then, even if there is a obturated jerk, but you want to see that you are not, causing any trauma to the bladder, what you will do?
We will use pure current, sir. We will do a small cut, stepwise small cut. We can use bipolar instrument if we are having bipolar set, and we can use lasers for fulguration if available.
Pure current will prevent the jerk.
Is there any advantage of end block resection? Nowadays, people say that instead of removing in the pieces, you can remove it end block. Dr. Maheshwari he has presented a paper also on that. Maheshwari ji.
Yes, sir. So the advantage of en bloc is not for obturator jerk. The advantage of en bloc is that, you see, normally when you do a TURBT, this procedure is indirectly against the classical teaching of malignancy treatment. Any other cancer, you would want to remove the cancer intact with a normal covering of a tissue over it. Here you have a cancer where you are breaking it into multiple pieces. This is not a standard principle of cancer treatment. When you break it into multiple pieces and at the end you leave behind a raw area, there is a possibility that the cells that break when you break the tissue, these cells can get implanted in the raw area and the risk of recurrence may increase. So with this in mind, en bloc resection was started, where the complete tumor with base of the tumor is removed as a single piece. The advantage is that the better quality histopathology tissue is available. The possibility of getting detrusor muscle is higher. Though this started with the intent of reducing the risk of recurrence, up till now it is not proven that it reduces the risk. There is a recent study, a multi-center study, which I think has got published just a couple of months back. That is one of the only study where they have said that the 1 year recurrence rate is lower. But otherwise, most of the studies say that the overall recurrence rate is same. Probably the major advantage will be that the chance of getting detrusor will be higher. Now, en bloc resection obviously can be done for smaller tumors. The tumor should be of a size which can come out through your resectoscope sheath. So, because the tumor, in contrast to TURP is more of a solid tissue in prostate, but the tumor is more fronded and fluffy. So, tumors up till 3 centimeters can come out through resectoscope sheath. So, if you have a tumor up till 3 centimeters, within 2 centimeters of the interureteric ridge, that is the ideal place for en bloc resection. En bloc resection has been described for tumors at every place, but at other places you would need a higher expertise. For very large tumors, there are two things which can be done. That the top part of the tumor can be resected with TURP, and the base with detrusor can be taken as an en bloc resection. That is one option. Second option is there are some reports of use of morcellator, which is used during HOLEP. So by morcellator, you can crush the tissue and suck it out. Because morcellator has a negative suction attached to it, so possibility of probably the risk of implantation that we would normally expect would not be there when you use a morcellator. So these are few things about it. You can use all energy sources. It has been described with bipolar, monopolar, whole wave laser, so whatever energy muscle section, couple of it can excise tumor as well as doing a point coagulation. So this was the innovation which got an award during a recent SIU meeting. So Indian who got this award. So that is one new thing which has come up. I recently saw 2 robots which have been devised only for en bloc resection. These were very interesting robots where through the resectoscope sheath, there are 3 channels which go in. Now there will be one channel which takes the laser, one channel which has a spatula which can help to retract the tumor on either side, and the third channel is for electrocoagulation. Now, these are all fancy things for our country at this time, but as far as we are concerned, en bloc resection for smaller tumors less than 3 centimeters within 2 centimeters of ureteric, interureteric ridge, and predominantly at the floor. So try not to do on the lateral wall and at the dome. The advantage, one more advantage of using laser is that the risk of obturator jerk will be 0. You can do the en bloc resection in patients who are on antiplatelet agents, which would be difficult if you are using the routine electrocautery.
Yeah, I saw your paper. Once you had shown us demonstrated how to do en bloc resection with the laser. It was very beautifully done.
Sir,
Yes, we had a publication in IGU.
I have one concern because it is the concept what you explained just now is applicable to the tumor which is of smaller size and which can be completely come out intact through that resectoscope sheath. Okay. In the rest of the places, if you go for en bloc resection by any way, you are again breaking. If large size tumor, suppose you are en bloc resected, again you have to broken into the number of pieces. So the principle of the cancer, what we have explained, it is defeated. In case of the large tumor, in case of the multiple tumor, so this concept may not be helpful. That's why the recurrence rate is same. Whatever the literature suggesting, the reason behind that is that only. If it is compared with the smaller size tumor and larger size tumor, then probably there may be some conclusion.
I 100% agree, sir, what you have said. So I was just saying that ideal case is a small tumor within 2 centimeters of ureteric ridge. So that is the ideal case. But then if the next question comes, can it be done for larger tumors? Yes, it can be done with the disadvantages that you have mentioned. And you, for removal of the tumor, you will either need to break it or use a soft tissue morcenter.
Agreed.
So ideally, yes, absolutely true. The advantage of doing larger tumors en bloc would be that probably you get detrusor muscle much better. You see, these days the concept for say looking at the histopathology of bladder tumor is I want a vertical as well as the horizontal extent of the tumor. In TURBT, it will be very difficult to get both vertical as well as the horizontal extent. And that will be possible only if I can excise the tumor en bloc with couple of millimeters of surrounding tissue. So if I do that and get a good depth of the tumor, then I get both vertical as well as the horizontal extent of the tumor. Now, again, the literature has not reached a stage where we know the advantage of vertical and horizontal extent, but these are things which people are studying at this time.
Totally agreed.
Yes, yes. Okay, so Aslesh,
Yes, sir.
the question is that after doing TURBT, would you like to put any medicine or anything?
Yes, sir. If my resection was good enough and there is no risk of, there was no intra perforation and it is maintained, then I will put the.
What is meant by good enough resection?
Sir, sir, what I meant is that if there is no injury or there is perforation, then I will instill intravesical mitomycin, sir.
So in simple word, complete resection, no perforation, no hematuria.
Yes.
Say uneventful resection. Na? If you want to use proper words, it will be clear. No?
So in which cases you will not do it?
Now you opened the Pandora's box.
Let us start with the size.
If
it is a 1 centimeter, half a centimeter tumor, you will do it?
Yes, sir.
Small tumor, you will do it? Is it necessary?
Sir, intravesical mitomycin is just reduces the recurrence, sir. And if it is looking like a low grade tumor, then I will put intravesical mitomycin, sir.
You said it reduces recurrence. What is the percentage reduction in recurrence? Anuj, no, it is not 12%. It is, I think, 23%. Okay, by the first study which was done for intravesical mitomycin, they came up with a 23% reduced recurrence at, if I am not wrong, at 1 year. Anyway, one simple principle of mitomycin will be that at the end of your resection, if you feel that this tumor is likely to need intravesical BCG, in those patients, don't give mitomycin. So a single tumor, fronded tumor, which looks superficial, where in all probability you would not be needing mitomycin, BCG, these are the patients you give mitomycin. If you are going to need BCG, then giving mitomycin makes no sense.
Yes, sir.
So suppose what are the other drugs other than mitomycin which have been described?
Epirubicin can also.
Epirubicin. Okay. What else?
Gemcitabine, sir.
Gemcitabine, thiotepa. I'm sorry. दीपक, मेरी एक मीटिंग चल रही है, मैं फोन लगाता हूँ या कल ही बात करें. The only drawback of mitomycin is the expense. The other drugs are slightly. So in a lot of centers, but other drugs are used. But literature-wise, mitomycin drug. If
Someone
you
has
don't
asked
have access to
mitomycin or
mitomycin,
mitomycin C.
yes, sir.
Mitomycin or mitomycin C. Someone has asked.
I think it is the same thing. I don't
Okay.
think these are different things. Mitomycin and mitomycin C are not different, but I stand corrected. I think they're the same thing.
Okay.
Electromotive mitomycin is completely different. It is used more in place of BCG. We are talking of mitomycin immediate post-op. So single installation of mitomycin, which is done at the end of TURBT, that is different than HIVAC, which is given in replacement for BCG. So single dose mitomycin should be given in any patient where you are not contemplating intravesical BCG, and when you are sure at the end of your resection that you have not caused any perforation. If you do not have mitomycin, other drugs can be used. You can use hypertonic saline. You can just give continuous bladder irrigation. Even that has been known to reduce all the circulating cells in the bladder. So these are few options. Mitomycin preferably should be given within, say, 24 hours, ideally between 4 to 6 hours of resection. And before giving mitomycin, there should be no active hematuria, because you will need to stop irrigation for some time. So obviously, if there is active hematuria, you will not be able to do that. So these are your prerequisites.
Fine. Good. Okay. Just show the working elements. Whatever was left behind, last time, we will just continue and finish. Brijesh.
इधर पे था ये
Yeah.
टूट जाएगा
So
ना
last time we
ये-
discussed little about working elements.
ऐसा नहीं करना चाहिए
Aslesh,
दीवार फेंकना चाहिए
Sir,
what is
नहीं
the
फेंकना चाहिए।
advantage? Which
तो सो जाओ।
double stem you will use or single stem you will use? And what is the advantage?
Sir, at our institute, we use both the single stem as well as double edge. There is no difference in between the activity of the single and double stem. The double stem just provides the stability to the loop.
No. So stability is more in this single stem working element or double stem?
It is more in double stem, sir.
No. In single stem, see, there is a channel for a stem. So stability, number one, stability is more in single. Paras, just tell us the advantages.
So the single stem is more stable. It has less chance of breakage during resection. There is less water and electric current leakage from the site of the hole from which the electrodes go.
Man,
And so there is more stability.
see, the first thing is there is more stability. Second thing is this double loop, Brijesh will show you. Okay, it is coming out from the channel, that is where the electrode is attached. So there the electrode is attached from behind. So the chances of damaging the loop at the end are very high because it bends. Okay, insertion is little difficult because you have to put a two stem into a two small hole, and they may not be absolutely parallel. That hole becomes little bigger, and then slowly, see, as you can see, in a single stem, you are going to put the electrode from above, and it is not coming in direct contact with the loop. But here, as you can just expand it and see. Show the next one, next slide. So this electrode is attached from behind, and there may be a leakage of water from there. At the same time, it can go into the system, electrical system. So the chances of electrical current spread is also more in that case. The most important thing is sometimes this double stem loop, it comes out during the resection. So these are the disadvantages of double stem. Nowadays, hardly anyone uses this double stem. Okay. We just go ahead.
These are already discussed.
Yeah.
Irrigation fluids.
Yeah, these are the different loops. So where you will use this? Aslesh?
This is a loop for bipolar TURP.
So this is used for what?
It can be used for resection of prostate, bladder tumor, and
It is one of the brands, sir. One of the brands which make such type of arrangements, sir.
this is of a Carl store, sir.
Stores, yes.
It is for resection or for the enucleation? Maheshwari,
This is
I
for
have not used
resection.
this. Dr.
Oh.
Maheshwari has used it?
No, sir, I have not
This is
used
for
this.
resection.
But I've seen people using it for enucleation.
I thought it is for enucleation. The lower one you make an incision and upper one that you push the lobe.
Mechanical dissection के लिए है sir.
Yeah.
Yes.
Upper part is for mechanical dissection.
It just holds the tissue there, sir. Mechanically, it holds it there.
Correct. Fine. Okay. We just go ahead. Yeah, all the accessories. Now, name these and tell me what you like to use. What are the different methods of retrieving the chips or giving the work? Aslesh.
Sir, this is a glass helix the original glass helix evacuator, sir. And the different methods are, one is with the helix evacuator, the other is with the disposable bladder evacuator, which is commonly used these days. Other is TUMI. With the help of a 50cc TUMI syringe, we can evacuate the content, sir.
What is
What
the
is
name
the
of the
advantage of
disposable bladder evacuator?
What, sir?
This
What
is
is
the
the name of
classical.
the disposable bladder evacuator?
That's what I was saying. This is the classical helix. But what is the disposable one called? It's written also on that.
Don't know the name, sir.
Okay, now how will you use this? Yes, it is called Eurovac. How will you use this helix evacuator?
What is the principle? Come on, tell me.
Have you seen it or not? Have you seen it or not? How it is used?
No, sir, I have not seen. The classical, I have not seen.
Okay, please go back to the picture of helix evacuator. So basically what you need to do is you need to completely fill it with saline. Get all the air out of this. Okay. Hold it in a way that lower chamber is always dependent. And then attach it to your resectoscope sheet and use this bulb for in and out. So
what
through
people
the upper
also do
chamber,
is
the
they,
water will go in and out.
yeah.
Because the tissue is heavier, it tends to drop in the lower chamber. But the biggest precaution is before you start using it, you need to get the complete air out of this.
So what people also do is they connect it to the TUR sheath where the connector is, and then they remove this balloon, the one which you use to give the wash. So then automatically the entire chamber fills. Then you reconnect it and then you give the wash.
Yes, and then you fill the balloon also with water and
Correct.
then attach the balloon there.
Yes, yes.
So what is the principle, Aslet?
The principle is that it creates the negative suction because after filling the evacuators completely with normal saline, I will close all the other I will close the inlet, and that will just connect the bladder and the evacuator. So the negative suction is created, and all the chips will come inside the evacuator.
So number one, when you press the balloon or that bulb, elastic bulb, okay, the fluid will go inside the bladder. And when you release, there is a negative pressure.
Yes.
So the fluid will come, it will be sucked and it will come back. And along with that, you're expecting chips also to come back. Now the chips are heavier. Okay. So it will settle down into the lower chamber. And that is why it is like an hourglass. The bottom is little larger. So all the chips will spread. And there is between this hourglass, the opening is little smaller. So again, when you push, the fluid from the upper chamber will usually go into the bladder. And the chips will not go back. Someone has written very rightly, it is called eddy current. So because the chips are heavier, it will settle down.
It is conventionally used helix evacuator. Now the people are using a modified helix evacuator. There is only one bottle.
Yeah, Eurovac.
Okay. So in that there is no two chamber, no that प्रेशर ये कुछ भी नहीं है, जस्ट एक बॉटल रहता है जो रिम तक भरना है और अटैच करके यूज करना, प्रिंसिपल सेम है.
So how, just tell us, just show that bottle and tell me how the same principle is applied and why it is better. Eurovac दिखाओ बेटा. Yeah. You know, this is based on which principle? Your ICD. So this inner tube has got multiple holes. So when you press the bottle, the fluid will go. The chips will come out from the center and it will settle down. And that tube is quite nearer to the bottom. So the chips will not go back.
इसमें भी एयर जाने नहीं देना है.
Yeah.
दोनों का एक ही है, इसमें भी एयर जाने नहीं देना. और तीसरा और एक ऑप्शन है, टुमी सिरिंज.
What is the advantage of Tommy syringe? What is the disadvantage?
Advantage is
The
that
advantage is a positive pressure. You are, if there are lots of clots or big chunk, this is a passive suction. That is an active suction. So there is one advantage. Second advantage is you don't have to fill up. You understand? You don't have to every time like this Eurovac, you have to fill it up with the fluid and then only can use it. That you don't have to fill up. What is the disadvantage?
To me,
Every time you get a pieces, you have to empty it. Otherwise, it will go back. And second thing, it is made up of glass. The piston may come out and it will break. Okay?
Yes.
Gita sir, anything else? Go ahead. Brijesh, show the other accessories. Yeah, this is the one. What is this connector? Ashley?
Foley adapter.
Okay. And how will you, suppose if you are assisting the surgeon, how will you give this?
So we'll give the Toomey syringe in a kidney tray.
Or
Or we will hold the outer, we will not hold the plunger, we will hold the outer sheath up with the
and
metallic and downward.
upside down.
Yeah.
Okay. The piston should remain up and the nozzle should go down when you are giving. Otherwise, the piston will come out and it will break. Okay. If you want to boil, how will you boil it? Ashley?
Sir, I don't know, sir.
See, this piston is going to be a lighter. It contains air. Now, if you put it inside that outer sheath, okay, then it will not get sterilized. So you have to keep it separately. So what you do, you tie it both. The fluid will enter into this sheath, and with the metal, it will go down. So along with that, a piston also will go down, and it will get boiled properly. Otherwise, it will float. Show another thing.
These are very interesting practical tips, sir.
Yeah. In our exam, they were asking us initially these questions only. Because that time, Eurovac and other things were not there. Na?
Not there, yes.
What is this?
Sir, it is a Paras.
High frequency monopolar cords.
Yeah, okay. But this one is for which working element?
Monopolar, sir.
No, which type of working element?
Single stem, sir.
Yeah, this is for, so say properly, no? This is for a single stem. Okay. So any questions on this? Okay, next. Yes, Ashlesh, now tell us.
Sir, this is a stone breaking alligator force.
What is this, Ashlesh?
Bladder, it is a bladder biopsy forceps, sir.
Oh, see properly.
It's a bladder stone breaking alligator force.
ब्लैडर परफोरेट नहीं करना है.
So how will you introduce it? Which sheet you will use?
It is used in a 25 French sheet.
You didn't tell the name of it. What is it called? Which stone punch?
So that is a different. Mormoy stone punch is a different set of assembly, sir. It is having a obturator, stone punch, teeth, everything. So this is a simple. So this is
Yeah. So what is it called?
so this is the assembly of Mormoy stone punch, sir. Having a visualizing sheet, a obturator, a 23.5 French cystoscope sheet with inner and outlet channel, and a stone punch at the top.
Yeah.
It is mainly used for breaking stones which are lesser than 2 centimeter and are not very hard.
And the earlier one?
Earlier one is for alligator forceps, sir. So it has an upper end which is fixed and the upper jaw which is fixed and the lower jaw is movable.
This is called a stone punch, and that is called a stone crusher. Here, with this, this one is used mainly for the stones less than 1.5 centimeter, where actually you should not hold it in the center, because then it will be very hard and you will break this stone punch. So punching is only at the periphery. So slowly, you take a small pieces, small bites, and make the stone smaller. The another one, that is a stone crusher, that you take the full stone in the its jaw and break it. Understood? Okay. Just tell me how we are going to introduce.
Sir, this set is having its own sheet with visualizing sheet also, and the direct vision also we can enter, or there is a obturator which can be connected to the sheet for indirect introduction of the sheet. And once the sheet is placed, then we put the stone punch inside and press. Hello.
What happened?
Hello. So for this, we will connect the sheet with the visualizing sheet and a telescope. We will introduce it. Then we will remove the visualizing sheet and we will put the stone punch. Then
Which telescope will you use with this?
so 30 degree.
Okay.
So the
Now,
classical description is a 12 or a 0 degrees because you want a front viewing telescope. But yes, it can work with 30 also.
correct. Because in this case, the lower jaw is going down. So with a 30 degree, you will be able to see the lower jaw. Now suppose you are breaking the stone and a small piece comes into between the jaw. It is not coming out. What we will do? Paras,
So it's in between the punch.
yeah, no. Show me the earlier alligator one. Bridget, many a time it has happened. See, you open the jaw, you are holding a stone, and when you are breaking it, because it is an alligator, there are serrations. The stone will break. Okay, and the small piece may remain behind the jaw, and it is not coming out. The jaw is not closing. What we will do now? Bridget, show the earlier one, na? Yeah. You saw it? Now the jaw remains like this, with a stone in between. It is stuck. What you will do?
No idea.
Aslesh?
No idea, sir.
See, many a time when earlier we didn't have laser and lithoclass and other things, we used to get stuck. And if you remove it, you cannot remove it because your 25 French sheet will not allow it to come out. And if you bring out like this, you are going to damage the urethra like anything. The one way is that you can take the lithoclass rod. Okay, remove there is all blind thing. You have to remove the telescope and you have to put that lithoclass till it reaches to the stone. And then you can use the lithoclass to break it or it comes out. The last thing is you have to open up the bladder.
So, after listening to the sir, both the instruments are dangerous. The first one is stone crushing forceps and another is a stone punch. The stone punch is comparatively sturdy than the stone crushing forceps. Both the instrument, the sheath usually is 25 French. Prerequisite, bladder should be full. Prerequisite number 2 for the forceps, you should not grab the size of the stone larger than that forceps opening. उससे बड़े साइज का स्टोन उसमें पकड़ना नहीं, otherwise it will get stuck and it will not get crushed. Okay. दूसरा ये जो लार्जर स्टोन पंच में कर सकते हैं, हार्डर स्टोन पंच में कर सकते हैं, लेकिन स्टोन जो फोर्सेप है वो पहले वाले जो ऊपर वाले दिखाए वाली, उसमें उसके साइज का ही स्टोन जो उसके दोनों ज्वा के बीच में बैठता है उतने ही साइज का स्टोन लेना है, ब्लैडर फुल रखना। और ये सब प्रोसीजर्स बड़े डेंजरस है, आजकल कोई नहीं करता, लेकिन ये इंस्ट्रूमेंट रख सकते हैं तो उसके बारे में पता रहना जरूरी।
So let's tell us the different ways of breaking the stone or removing the bladder stone.
Sir, if it is a small stone, then a laser fiber with thulium laser or holmium laser, the stone can be laced and then it can be evacuated. And if it is a larger stone, then we can give the patient the option of suprapubic cystolithotry and or open surgery, sir. In the suprapubic, sir, we can use the emplatz sheath and through that nephroscope, and then we can use the lithotripsor, and that way we can easily do the bigger stones, sir. And for smaller stone from per urethra, only lasing will be sufficient.
Per urethra, you can't use lithoclass?
We can use, sir. We can use, but
so your basic should be clear.
Yes.
Stone in the bladder can be accessed by two ways. One is by suprapubic way, another is by periurethral way. Okay, when stone are larger size, multiple stone suprapubic. Single stone less than 2 to 3 centimeter or smaller size stone periurethral. The purpose is the instrument should not be inside the urethra for longer duration. Okay, that's why the stone size should be smaller. And in such situation only the cystourethral lithotripsy can be done. Correct. PCCL के लिए specific indication है multiple stone larger stone. ये वे के हिसाब से क्लासिफिकेशन हो गया. As per then pneumatic. हर बार लेजर ही क्यों भाई, मेरे पास लेजर नहीं है तो हम स्टोन नहीं निकाल पाएंगे. तो वन न्यूमेटिक भी है, लेजर भी है, कौन सा भी यूज करो जिसको जो पसंद है. तो कौन सा इजी रहेगा और कौन सा जल्दी होगा?
Lithotripsor will be easier and faster.
Which lithotripsor? Pneumatic. Yeah, laser.
Sir, I personally feel that lithotripsor is faster than laser. Laser takes very much time.
Yeah.
तो मुझे भी वैसा ही लगता है, लेकिन सर को पूछ लेंगे.
No, definitely. We have used it many times. I don't like laser because laser will take a very long time. I'll tell you what we do.
ऐसा नहीं है सर.
Listen, if it is a very big stone, when it is a very big stone, round stone, it is very difficult for the litho class. So what we can do is, if you are going to do per urethra, I'm not talking of its property. If you are doing per urethra, initially you can use laser and make multiple holes so that it becomes rough. After that, litho class, make multiple pieces. After, when there are multiple pieces, you evacuate, and whatever small pieces remain, you can use alligator stone crusher.
Pankaj sir का opinion sir, क्योंकि density of the stone and the type of energy source used, that is important one link. So that can be again come into play while deciding the. That's what
Absolutely, sir. Most often these are infection and uric acid stones. So they would dust very well even with laser. But yes, if it's a very hard calcium oxalate stone, large stone, then I agree that laser will take a lot of time. And one more specific indication of PCCL would be when you are treating pediatric patients. Because in children, we would want to spare the urethra.
Yeah.
Okay, one
And it is
just fun
difficult to remove the
question.
stone pieces.
One just fun question. What is the difference between cystolithotriti, cystolithotripsy, and cystolithola?
आवाज ब्रेक हो रहा है सर आपका.
Sir, cystolithoplexy is a direct removal of stone. Cystolithotrity is mechanical energy is used. Cystolithotripsy is when laser energy is used.
No.
Cystolithoplexy is a direct removal. Cystolithotomy is open and.
अरे भैया डायरेक्ट रिमूवल मंच कहाँ से रिमूवल करेंगे? क्या जादू की कांडी?
Cystoscope sheet से. Sheet से sir.
Then why it is called as Lepexy? वो तो evacuation of stone होगा फिर. वो वर्ड का कुछ मीनिंग होगा ना? नहीं तो सिस्टोस्कोपिक इवैक्यूएशन और रिमूवल ऑफ स्टोन बोलते थे ना?
So just try to find out. Okay, every word has a
Someone
different.
has given you in the. Someone has already given you that mechanical breakage is triti, litho breakage is tripsy, and taxi is a removal intake.
I don't agree with this, sir, but let's check.
Yeah.
सर सिस्टोलिथोलेपेक्सी मुझे जितना पता है वो स्टोन को क्रश कर देते हैं की जगह पे. जैसा स्टोन पंच में होता है वैसा वो सेम प्रिंसिपल लेपेक्सी में है.
Jamin, from where you got it, please post it.
Campbell में लिखा है ये.
अच्छा, it is given in the Campbell.
What Campbell में क्या लिखा है Campbell में?
Cystolithoplexy is intact removal of stones. Triti is mechanical and tripsy is using other model energy.
100% whatever I can remember, litholapexy is not intact removal of stone. I agree with Gite Saab that in litholapexy you crush the stone, and I think I will need to check. I am not 100% sure.
सर वो वैसा ही है. कैम्बेल में लिखने दो, नहीं तो कहीं पे भी लिखने दो. सिस्टोलिथोट्रिप्सी मतलब मल्टीपल स्टोन फ्रैगमेंट करना है.
मैकेनिकल
मतलब
यस
क्रश करके स्टोन निकालना है. सिस्टोलिथोटॉमी तो इंटैक्ट निकालना है जैसे ओपन सर्जरी का.
वो तो चौथा टर्म है.
ट्रिप्सी एंड लेपेक्सी ऐसे तीन ही वर्ड है.
Cystolithotripsy is when what we do with laser, sir. We completely crush it and remove it.
Sir, cystolithotripsy, if you do with laser or pneumatic, doesn't matter.
Whatever, yes.
Breaking the stone and what I feel is, you see, when you use these mechanical devices, say the Mormaer sponge or the
lithoplexy.
That is litholapexy or that is lithotriti?
No, sir. Cystolithotriti and tripsy is near about same. That is breaking the stone in multiple pieces. That is tripsy oblique triti. Lepexy is crushing the stone, in short, and the term is removal of the stone.
I think so, sir, because lithotriti and lithotripsy are used interchangeably.
क्योंकि मेरा जो बॉस था उसने ऐसा ही पढ़ाया था, शायद गलत.
Lepexy, everyone is telling in the chat box, they are saying Lepexy is intact removal. That is what again I think we should find out.
Find out, sir. We will find out, sir. No issue.
Yeah. Fine. Good. So
दिए
here
ना उसमें
today,
literature भी दिया है sir.
someone has asked how you are going to use lithotripsy for urethra. So we have got a special instrument made. It is called cystolithography. That much. When there is no actual word for that. You know, there is one instrument which you put through the 25 French sheath, and from the channel you can put the rod, lithotripsy rod.
Patanker bridge, sir. Patanker model. Patanker.
Okay. So I think if anyone has got an image, you can show that. So here we are finishing the lower tract. Okay. Next time we will do the upper tract. Again, whoever is answering, read as per the questionnaire given earlier. It will be very easy. Gite sir, any other question? Maheshwari? गीते सर?
हाँ सर, मैं वो ढूंढ रहा था लपेक्सी का, तो अभी
हाँ.
फिलहाल तो कुछ नया क्वेश्चंस नहीं है.
Okay. Fine. Maheshwari ji, you want to ask anything? Hiren?
No, sir. I think well covered.
Well covered. Na?
Enjoyed
So,
today's session.
yes. So now upper tract. Upper tract,
Sure.
it is your domain and Hiren's domain. So,
Yes sir.
yeah?
Sir, I wanted to
Okay.
ask you one question. You had made one sheet, no sir, for using in for bladder stone with lithoclast.
Yeah, that was the same one which was used then. These people, they made it. The
No,
one
but
which I had.
you had made, sir, when we were residents. That's what I remember. You had made one
Yes,
sheet.
yes.
Yeah.
So now
Okay,
it is
sir.
modified and it is used the same one.
Yes,
I
sir.
think Patankar or someone. That name. I don't know what is the name of that sheet.
Yes, sir.
Fine. Okay.
Okay, sir. Good night.
Okay. Thank you, all of you.
Bye.
Good night, sir.
Good night.
Good night.
Well answered, boys.
Yeah, yeah. Asleep is good.
Thank you, sir.